James Davis.
Thank you, Chair. I'd just like one more go at trying to determine the merit between inpatient care and community-based care. We've established there needs to be more community-based care, but just as a basic guide, Dr. Courteney, what proportion of current inpatient patients with autism and learning disabilities are inappropriately in those facilities currently, would you say?
I can't give a definitive answer to that, but the data, having had a look at in NHS England's data set, they're estimating that nearly a third of people really would benefit from being in other provision, and people are waiting for discharge. So the difficulty, I think, with discharge is that there aren't enough incentives in the system to actually get people out of hospital once they're in hospital, because we really need to be moving people out, but what are the levers that we have to actually enable this? And Ian was earlier referring to hospitals that will, particularly in the independent sector, that will be relying on admissions. So we actually need to be looking at these levers and examining them, what are the ones that we can actually use to facilitate discharge for people. Because in many ways, it's in the interest of a lot of people in the system for people to remain in hospital, which I don't agree with at all. And I think we should be moving towards helping people to be discharged and seeing what incentives we can bring in.
Thank you. And one further question. You've proposed a new role, a learning disability physician. Why do you think that such a role could be useful or is necessary?
Oh, this is based on the model that they have in the Netherlands. It's because of the level of comorbidities that people with intellectual disabilities have. They have usually on average around 11 comorbid disorders compared with people in the general population who would maybe have 5. And this is data which is being produced by Professor Kinnear in Glasgow. Again, it comes back to this word of complexity. People have a lot of disorders occurring at once. And in fact, the medical staff that we have in hospitals in particular may not necessarily be very or aware of how they're presenting in people with learning disabilities. So what we're actually suggesting is that we have developed specialists who will be more skilled in working with people with learning disabilities and understand comorbidity, multimorbidity, complex disorders. My ambition is, in fact, that every trust in the country would have at least one physician, one skilled decision-making doctor within an organisation who can actually work with people with learning disabilities who have these physical health problems, work with their colleagues, the doctors that is, work with families, and also work with GPs supporting them. And if we're able to achieve that, again, based on the model that they have in the Netherlands, I suspect, in fact, we would avoid hospital admissions, we would reduce the length of stay, and we would provide a better quality of care for people with learning disabilities who have physical health problems, whether they're cardiology problems or whether they're renal problems. But the most important thing is, in fact, is having a skilled senior doctor actually supporting hospital staff in managing these complex problems that people have.
Thank you.